Polycystic Ovarian Syndrome, PCOS. Bill D. Hampton, MS4. Endocrinology Department. October 19, 2000. PCOS. Overview Definition Statistics Onset Clinical History. Signs and Symptoms. Oligomenorrhea. Androgen excess. Infertility. Obesity. Insulin resistance. Insulin resistance. Physiology. Differential diagnosis. Ovarian hypertrichosis. CA. Cushing's syndrome. Androgen-producing neoplasm. Treatments. Future research. PCOS, definition. A condition commonly characterized by hirsutism, obesity, menstrual irregularities, infertility, and enlarged ovaries, thought to reflect excessive androgen secretion of ovarian stroma. Hyperandrogenism with chronic anovulation, with exclusion of such secondary causes as non-classic CA, Cushing's syndrome, and hyperprolactinemia, PCOS. Statistics. Most common endocrinopathy of women of the developed world. Affects 120 reproductive-aged women. Responsible for 9/10 of cases of oligomenorrhea. 2/5 women show glucose intolerance. PCOS, pathophysiology. Although it is the most common endocrinopathy of women of the developed world, the fundamental pathophysiologic defect has not been determined. PCOS, onset. Menarche, often followed by menstrual irregularity for 1.5 years. If irregular bleeding persists beyond this time, and certainly after 3 years, then PCOS must be suspected. PCOS, clinical history. 1. Appearance of hirsutism is gradual. 2. Episodes of irregular bleeding are not typically preceded by premenstrual symptomatology, highly suggestive of an ovulation. 3. The onset of symptoms tends to be recognized at or soon after puberty. 4. Despite similarities with other conditions, PCOS occurs far more frequently. PCOS, oligomenorrhea, lack of awareness before menses. Varying degrees of bleeding. 85% to 90% due to PCOS. 30% to 40% of amenorrhea due to PCOS. Not all patients are anovulatory. PCOS, androgen excess. 4/5 patients demonstrate excessive hair growth. Involvement of face and chin, typically. Male pattern of distribution, chest, perineum, back, extremities. Hair growth should be gradual in PCOS. Virilizing signs, clitoromegaly, male body habitus, are not usually seen in PCOS. Acne is not specific to PCOS. PCOS, infertility, most common presenting complaint. Increasing evidence suggests women with PCOS have incidence of miscarriage, unknown mechanism. Not all patients are anovulatory. PCOS, obesity. Half of PCOS women are obese. Android pattern of obesity. Distribution of obesity tends to be waist to hip ratio. PCOS, insulin resistance. Greater than 50% adult women with PCOS exhibit insulin resistance and hyperinsulinemia. 40% of patients with PCOS demonstrate glucose intolerance. Hyperinsulinemia more prevalent in obese PCOS patients but is seen independent of obesity. Molecular mechanism of insulin resistance in PCOS is unknown, however. PCOS, insulin resistance. Acanthosis nigricans, an eruption of velvetory benign growths and hyperpigmentation occurring in the skin of the axilla, neck, anogenital area, and groins, associated with internal malignancy, endocrine disorders, or obesity. Responsible factors remain unidentified. Associated with insulin resistance. Close association suggests that insulin may induce, contribute to its development. No correlation with severity of insulinemia. PCOS, insulin resistance. Assessment of insulin resistance may be bioral, For glucose tolerance test. Because of long-term health risks, insulin secretion should be evaluated once diagnosis of PCOS is established. However, determination of insulin resistance is not essential to diagnosis of PCOS. PCOS, hyperinsulinemia. Due to insulin resistance seen in PCOS. Important mechanism in ovarian hyperandrogenism? Radthaka cells in culture respond equally when exposed to LH or insulin, but have a synergistic greater response when given both LH and insulin. Insulin and IGF-1 can act as chogonadotropins enhanced LH secretion. PCOS, hyperinsulinemia. Potentiates ovarian hyperandrogenism by enhancing LH secretion from THACA cells. Potentiates 17-hydroxylase. Suppresses SHBG capacity, which in turn, raises total level of unbound, free, testosterone. PCOS, hormonal and metabolic profile. Hyperandrogenism? Total testosterone. Androstenedione. Sex hormone binding globulin, SHBG. Acyclic estrogen production. Insulin, with insulin resistance. PCOS, hormonal and metabolic profile. Hyperandrogenism? Insulin amplifies gonadotropin-induced androgen production by isolated ovarian tissue. Insulin acts synergistically with LH to promote ovarian hyperandrogenism. Insulin and IGF-1 stimulate insulin receptors on ovarian thecal and granulosa cells as cogonadotropins, thus amplifying androgen production. PCOS, hormonal and metabolic profile. Total testosterone. Insulin negatively regulates SHBG, which in turn allows for levels of unbound testosterone. Insulin also promotes ovarian and adrenal hyperandrogenism, which will also total serum testosterone. PCOS, hormonal and metabolic profile. Androstenedione. Insulin promotes gonadotropin-induced androgen production by isolated ovarian tissue. Insulin negatively regulates SHBG. PCOS, hormonal and metabolic profile. Sex hormone binding globulin, SHBG. Insulin negatively regulates SHBG. PCOS, hormonal and metabolic profile. Acyclic estrogen production. PCOS gonadotropin pattern is typically LH and FSH. Urinary studies have shown an abnormal, erratic pulses of LH secretion. PCOS, hormonal and metabolic profile. Insulin, with insulin resistance. 1. After laparoscopic ovarian cautery, significant decreases in testosterone and androstenedione were observed, but there was no effect on insulin resistance or lipoprotein abnormalities associated with PCOS. PCOS, hormonal and metabolic profile. Insulin, with insulin resistance. 2. After amplifying the entire coding region of the insulin receptor gene, Talbot, et al. 1995, found that insulin resistance in subjects with PCOS is not commonly a consequence of missense mutations in the insulin receptor gene. Differential diagnosis: ovarian hyperthecosis. An unusual proliferative condition in which the ovary contains nests of luteinized THACA cells scattered throughout the stroma. The minimal form of ovarian hyperthecosis has been seen in PCOS, suggesting a continuous spectrum of disease. Differential diagnosis: congenital adrenal hyperplasia, CAH. Made up of several enzymatic defects. Autosomal recessive inheritance pattern. Best approximation to PCOS is incomplete 21-hydroxylase deficiency, accumulation of 17-hydroxyprogesterone, androgen precursor, production of androstenedione and testosterone. Hyperandrogenism. Unlike PCOS, CA has severe hirsutism, clitoromegaly, regular menses, and short stature. Differential diagnosis: Cushing's syndrome. Clinical features result from excessive cortisol production. Signs/symptoms include obesity, hirsutism, acne, and irregular menses. Unlike PCOS, Cushing's also has moon-like facies, buffalo hump, HTN, muscle wasting, abdominal striae, and osteoporosis. Differential diagnosis: androgen-producing neoplasm may arise from ovary or adrenals. Signs/symptoms include functional hyperandrogenism, severe hirsutism, male body habitus, virilization, clitoromegaly, acne, voice lowering, irregular menses. Unlike PCOS, these symptoms typically have a rapid onset, progressing over a matter of months. PCOS diagnosis: clinical diagnosis with laboratory exclusion of other causes. Labs: serum total testosterone, androgen-producing tumor of ovary. Labs: DHEA sulfate, androgen-producing tumor of adrenal. Labs: 17-hydroxyprogesterone, CA due to 21-hydroxylase deficiency. Labs: despite widespread practice, LH/FSH ratio is insensitive, with less than 50% of PCOS/PTS having an abnormal value, and less than 20% having a ratio of greater than 3:1. PCOS diagnosis: imaging: ovarian morphologic characteristics. As many as 1/5 women have PCOS features on US, while only a fraction also have hyperandrogenemia and menstrual irregularity. Combinations: ovarian morphologic characteristics with elevated circulating androgen value, PCOS diagnosis. Suggested labs: level of unbound testosterone, provides best correlation with hirsutism, and because SHBG tends to be negatively regulated by insulin levels, an unbound, bioavailable testosterone level may reflect the combined effects of insulin resistance, insulin and SHBG, and ovarian and adrenal hyperandrogenism, total circulating testosterone. PCOS goals of therapy: normalize the endometrium, antagonize androgen action at target tissues, reduce insulin resistance, correct anovulation, if necessary. PCOS treatment dilemma: because the primary cause of PCOS is currently unknown, treatment options are at present symptom-based. PCOS treatment options: gold standard, weight loss, diet, and exercise, as little as 5% of initial weight, has resulted in lower circulating androgen levels, spontaneous resumption of menses, and decreased levels of circulating insulin. PCOS treatment options: infertility, clomiphene, Clomid, a partial agonist at estrogen receptors in the pituitary, prevents feedback inhibition, which increases LH and FSH ovulation. 4/5 women ovulate with Clomid alone. Small studies have shown significant improvement in ovulatory response with addition of metformin, glucophage, or INS1, but population is 20% to 50% of PCOS/PTS who are Clomid non-responders. PCOS treatment options: hirsutism, anti-androgens are very effective, however, their use is precluded in fertility treatment because these agents suppress ovulation or have potential teratogenic effects. Anti-androgens have been shown to significantly improve insulin sensitivity in PCOS by partially reversing the peripheral insulin resistance associated with hyperandrogenism, with greater effectiveness in lean subjects and no significant improvement in obese patients. PCOS treatment options: oligomenorrhea, oral contraceptives, OCs, are considered the first line of treatment for irregular menses, however, they also are clearly impossible as concordant infertility therapy. Furthermore, there has been some evidence that OCs may actually worsen insulin resistance in PCOS, and they may accelerate the progression of impaired glucose tolerance and type 2 diabetes. PCOS treatment options: anti-diabetics, drugs that improve insulin action have consistently been found to improve reproductive abnormalities in PCOS. Small studies have demonstrated conclusively that a reduction in serum insulin levels is associated with a reduction of ovarian androgen secretion and PCOS, because hyperinsulinemia, ovarian androgen secretion and SHBG. PCOS, anti-diabetic agents. Metformin, glucophage, a biguanide whose major effect is seen in hepatic glucose output. Improvement in testosterone and free testosterone levels in obese patients. SHBG, free testosterone, improve ovulation rates, and improve ovulation in response to clomiphene, Clomid. Also free androgen levels in lean PTS. Also demonstrated weight loss in PTS. PCOS, anti-diabetic agents. Metformin, glucophage, has not been shown to total androgens as a marker of ovarian androgen secretion, suggesting metformin's MOA is through SHBG. In studies where metformin serum insulin, same studies also show serum testosterone, the converse is true, thus the two seem to be interdependent. -30% to 50% women shown to experience regular menses on metformin. PCOS, anti-diabetic agents. Metformin, glucophage, some, but not all unsuccessful trials have involved extreme cases of obesity, suggesting metformin is less successful among the very obese. Variability in dosing also does not clearly correlate with efficacy. Metformin has no known teratogenic effects, but this reflects a lack of substantial body of evidence with women of reproductive age using the medication. PCOS, anti-diabetic agents. Troglycerone, Rosalin, a thiazolidinedione that directly reduces insulin resistance and circulating insulin levels. Demonstrated A and circulating androgen levels in women with PCOS. Studies have shown an improvement in insulin sensitivity and reduced circulating androgen levels with higher doses, 200 mg versus 400 mg. In free testosterone levels also seen with concomitant SHBG. PCOS, anti-diabetic agents. Troglycerone, Rosalin, some evidence exists that suggests that the thiazolidinediones can directly inhibit ovarian steroidogenesis. Most promising, however, is a study of troglycerone that included women who were just as obese as women who failed to respond to metformin, suggesting that troglycerone might be more effective in the severely overweight, BMI greater than 35. PCOS, anti-diabetic agents. Pioglitazone, Octos, rosiglitazone, Avandia. As of the September 2000 publication of one of the cited articles, no published reports are available of either drug in the treatment of PCOS. If the effects of troglycerone are applicable to all members of the same drug class, it would be anticipated that rosiglitazone and pioglitazone would be effective in the treatment of PCOS. PCOS, anti-diabetic agents. Dichloroinositol, a naturally occurring substance that seems to improve insulin action by increasing insulin signal transduction at the post-receptor level. In 20 obese women with PCOS, dichloroinositol improved serum insulin levels and serum androgen levels to about the same degree as other agents. PCOS, anti-diabetic agents. A word of caution. None of the insulin-reducing medications can be adopted as first-line therapy for PCOS because not all women with PCOS are insulin-resistant, and it is not clear that insulin resistance is the primary defect of the heterogeneous disorder of PCOS. More importantly, none of the drugs has been administered for long enough periods of time or to a sufficient number of subjects to allow an evaluation of any of the critical clinical endpoints or to prove superiority over other established therapies. PCOS, anti-diabetic agents. Duration. To date, the longest study of insulin-reducing agents for the treatment of PCOS has been 6 months. Menstrual dysfunction. Although the improvements are encouraging, careful evaluation of persistent ovulation rates must be performed before it can be concluded that insulin-lowering drugs are acceptable therapy for irregular menses. Infertility. Before insulin-lowering drugs can be used, their safety, their efficacy, and their cost relative to other potential therapies for infertility due to PCOS must be evaluated. PCOS, anti-diabetic agents. Combination therapies. Because of the potential direct and unique beneficial effects of insulin-lowering drugs on metabolism, studies must be performed to evaluate their efficacy in combination with other therapies, especially oral contraceptives. References. Correction of hyperandrogenemia by laparoscopic ovarian cautery in women with polycystic ovarian syndrome is not accompanied by improved insulin sensitivity or lipid lipoprotein levels. Lemus, Jacqueline Endocrinolometab, 1999 November, 8411, 4278-82. Polycystic ovary syndrome. Gudasviti, Endocrinolometab Clin Northam, 1997 December, 26-4, 893-912. Molecular scanning of the insulin receptor gene in women with polycystic ovarian syndrome. Talbot Jha, Jacqueline Endocrinolometab, 1996 May, 81-5, 1979-83. Diagnosis of polycystic ovary syndrome. Chang R.J., Endocrinolometab Clin Northam, 1999 June, 28-2, 397-408, 7. The insulin resistance in women with hyperandrogenism is partially reversed by anti-androgen treatment, evidence that androgens impair insulin action in women. Moghetti P., Jacqueline Endocrinolometab, 1996 Mar, 81-3, 952-60.